Today we will do a small approach about any patient coming with epilepsy. What is epilepsy? Okay, what is seizure? Okay, epileptic seizure is a clinical manifestation. It's a clinical manifestation. So epilepsy is a clinical syndrome. Not every patient, if he will faint, lost consciousness, we will say that he is having seizure. It's a clinical manifestation of what? Of excessive and hypersynchronous abnormal cortical neuronal activity. To have a seizure, we should have 6 centimeters of neurons to activate at the same time, at the same moment, okay, to have a seizure, clinical seizure. So we define it as a seizure. It's a group of neurons that they fire at the same time, at the same second, okay, and spread to involve all the brain with the clinical manifestation to define that this patient is having seizure, not epilepsy. Seizure, it is a clinical findings. Epilepsy, it's a syndrome, okay? When I say that the patient is having epilepsy, he should have more than 2 seizures and above, okay? And other clinical manifestation. If I know I will have only 1 seizure, you will not say that Ahmed Fawad is having epilepsy. You say only that I have seizure. What happened? Dr. Midhat will told you Dr. Ahmed Fawad fainted and he was shaking, so he had 1 seizure. Okay? Epilepsy, if I have a back history of seizures and I am on medication, so this patient is epileptic. He has epilepsy. But epilepsy, it has a big umbrella. We have many syndromes and diseases of epilepsy. It's not one disease, okay? It's not like hypertension, even hypertension and diabetes. We have diabetes type 1, we have diabetes type 2, we have hypertension, we have mild, moderate, severe, and so on, okay? Epilepsy, it's a big name, but under its umbrella, we have many diseases and what we call it syndrome, okay? So epilepsy is defined as 2 seizures and above. Any first seizure we don't treat. First seizure we don't say that this patient is having epilepsy. He had 1 seizure. It's according to the International League Against Epilepsy. They defined epilepsy as having 2 seizures and above. Okay? It's very common disease, epilepsy. It's not a rare disease, and you see, according to our practice, you see it's not a rare disease. It comes immediately after stroke, okay, and depression, epilepsy. It's not like Parkinson, like multiple sclerosis. They are rare, they are not very common diseases, but epilepsy more common, okay? So, and remember that, and you see in our practice in EMU, 20 to 30% of our patients, they are refractory to treatment. What we mean refractory, that they are taking to adequate, okay, focus on my terminology, to adequate anti-epileptic with adequate doses, okay, and he is still having seizure. So we name that this patient is refractory. For example, if the patient is having focal seizure or generalized seizure, idiopathic generalized epilepsy, if he is having focal seizure and he is on, for example, Dipakine 500 twice daily, and he is taking, for example, Keppra plus 500 twice daily, and he is still having seizure, we don't say that he is refractory, because he's still taking small doses of Dipakine and Keppra, and Dipakine is not the adequate medication for focal epilepsy. He should take, for example, Tegretol or Vimpat or Triliptal, which are sodium channel blockers. Okay, so Dipakine 500 twice daily, Keppra 500 twice daily, focal seizure, and he's still having seizure, we don't call it refractory. If he is taking Keppra 2000 twice daily, Triliptal 900 milligram twice daily, still having seizure, yes, he is refractory, because we reached the maximum doses of the adequate medication for this specific disease or syndrome. Clear? Okay. In pediatric, epilepsy is the most common. And in adult, in elderly, I mean, we see from age 10 till 60, the epilepsy is not very common. Okay? It's common in the pediatric population from 0 to 10 and above 60. From 0 to 10, it's clear because most of our electroclinical syndromes of epilepsy are starting from the childhood. That's why we see more epilepsy in pediatric. Okay, 5, 6, 10 years, childhood absence of idiopathic generalized epilepsy like juvenile absence or juvenile myoclonic epilepsy. So this is clear why in pediatric, right? But why it's also increases after the age of 60, because we have more strokes, we have more tumors, we have more intracranial bleeding, car accidents, and so on. So we have a cause that can predispose the patient to have seizure. At the age of 30, you don't have tumors. Rarely you see tumors, for example, strokes, intracranial bleeding, AVM, atriovenous malformation, or cavernous angiomas, right? That's why the number of epilepsy patients in this age group is much less. But it also occurs. But the most is above the age of 60 and below the age of 10. Okay? Now I'll present you a case, okay, to see how we have to approach patients, and it's also for physicians, not only for you as nurses. I will give you brief. For example, a 27-year-old man present to the emergency department with a history of loss of consciousness. Loss of consciousness doesn't mean seizure. Loss of consciousness can be in patient with syncope, neurocardiogenic syncope. If I have low blood sugar, I can have also loss of consciousness. Okay? If I didn't sleep much, I didn't eat much, I can have loss of consciousness. Okay? So here, I don't say that the patient is having seizure. He had a spell. Okay? Whatever the spell is, okay, you tell me, and the resident or registrar, he call me. If he knows what he is doing, he will tell me that we have one patient that he had one spell of loss of consciousness, okay, or fainting, okay. So I should ask myself, is this a seizure or not a seizure? Because all of these syndromes can have loss of consciousness. That I can lose consciousness if I have syncope. If my blood pressure will drop, I will lose consciousness. If my heart rate will be 40 to 50, I can lose consciousness. If I have low blood sugar, I can lose consciousness. Transient ischemic attack, narcolepsy and parasomnia, which is sleep disorders, can have loss of consciousness. Benign positional vertigo, if I sit down and I stand up immediately, in some patients they become dizzy and they can faint, okay? But the trick here is that, oh, but doctor, when he fell down, he shaked. Okay, so what? If I don't have a clear EEG that this is associated with spikes or sharp waves or rhythmic delta activity, rhythmic changes on EEG, he can shake. Syncope, hypoglycemia, migraine, parasomnia, benign position. If the patient will lose consciousness because the blood supply to the brain decreased, okay, we can have some jerks. It doesn't mean that if you see jerks, oh, this is a true epilepsy or seizures. You only shake. So myoclonic jerks can associate it and be seen with patient who doesn't have epilepsy. Clear? So shaking doesn't mean that this is a true seizure. Okay? Any drop in blood pressure, in blood sugar, in heart rate can develop some jerks. So all of these syndromes or diseases can associate it with loss of consciousness, like intermittent increase in intracranial blood pressure inside the brain, and of course don't forget the psychogenic non-epileptic spells. Nurses who are working in EMU, they have seen a lot of cases of psychogenic, and you see that they can lose consciousness, they can faint, they can shake, they can move, they can sometimes bite their tongue, they can have urinary incontinence. The psychogenic, they can have fractures, they can have severe injuries, cut wounds, okay, from psychogenic. You will tell me how it's only we see it in epilepsy. No, they did a big study on several patients with psychogenic in Europe and in States. They saw that psychogenic, although it is psychogenic, not true seizure, they can develop any kind of traumas. Okay, even intubation, they can be intubated. They can drop their saturation down to 80%. And when they go to emergency, the emergency doctor will see that we have desaturation, they will intubate him. Or if he doesn't know the history, he sees that the patient is shaking, losing consciousness, he will give him Valium, right? This is the traditional, he gives him Valium, and after they give him Valium, the saturation will drop. Okay, he has desaturation, intubate the patient and send to ICU. Although the diagnosis is psychogenic. Only one thing that psychogenic rarely, almost rarely they are having is the burn. They don't burn themselves. Other than burns, they can develop whatever you want. Urinary incontinence doesn't mean seizure. Tongue biting usually in the anterior part of the tongue, but also they can bite their tongue laterally. Okay, they can dislocate shoulders, they can do fractures, they can have cut wounds, except burns. Is it clear?
Yes.
So all these syndromes, we should think about them before saying that this is a seizure. So when you remember, the patient has loss of consciousness, we ask ourselves, he had a spell. We have to ask ourselves, is this seizure or not, right?
Yes, doctor.
Yes.
So how we can diagnose one psychogenic without EEG, without an EEG?
The doctor can diagnose. If I see the patient in my clinic, I usually can say he is psychogenic. But how can I confirm to his parents and to the patient? I should have a solid document in my hands. Okay? From my experience, from my practice, me or Dr. Maher or Dr. Amr, we got the experience to know that this is a psychogenic, not a true epilepsy. Of course, some cases they are difficult, but most of the cases I can see, okay? And I will teach you how to know. But without doing video EEG, you cannot confirm the diagnosis. The patient, he should have the seizure or the spell between brackets, okay? On the system, on the video EEG, and I will see the EEG, what's going on. No changes on the EEG, and he is having the seizure, and I can induce it by hyperventilation orthotic. Hyperventilation orthotic, it is in psychiatry, it's as if I doing by suggestion. I tell the patient that you will faint. And you see what we are doing. He thinks that we are doing something extra, okay, something supernatural. Okay, he thinks that he will faint, and usually they faint, right or not?
Yes.
And you see in most of our cases. Okay, and the parents should be present because to document that. I ask the parent that this is the spell. He will say yes or no, and I review the EEG. No EEG changes. Okay, so this is psychogenic. Don't think about frontal lobe epilepsy, because sometimes the frontal lobe epilepsy that originating from the frontal area can sometimes be difficult to differentiate from psychogenic. But by practice, by doing EEG, usually frontal lobe epilepsy, they have seizure at night, okay? And few things I will show it to you. That the patient fainted, right?
Yes.
When he fainted, he having some jerks. It's myoclonic jerks. It's a true myoclonic jerks. Okay? This is syncope. This is a study done in Germany. They induced hypotension and bradycardia by doing Valsalva maneuver. They hold their breath and they tell them to stand up immediately. They lose consciousness, and we see how they. Another case, she fell down. You see, this is jerks. If any doctor or nurse, you will see this patient, you will say, oh, this is a seizure. Okay? From the history, From the EEG, I know if I have the diagnosis of syncope or neurocardiogenic syncope, I know that this patient can have some myoclonic jerks, okay? No EEG changes, this is syncope, neurocardiogenic, this is not seizure. But if the doctor is not aware of this syndrome or disease, doesn't have expertise, or nurses first time see this patient, they think that this is a seizure. Although this is not a seizure. Patient is lying in bed, right? As we are doing in our practice, right? She started shaking all over. If any doctor or nurse will see, they will call the doctor on call, come please, the patient is having seizure. But if I see it, okay, I can tell that this is not a true seizure. Okay? Why? You will ask why. Right?
Yes.
Simple question.
And
Don't
some
afraid
patient,
to
some
ask.
patient has to maybe real seizure, maybe with psychogenic seizure.
Of course.
How you will
So,
know
what
without-
Mahmoud is saying that, of course, in some rare instances, we have patient who is having true seizure and psychogenic. But this is not the common scenario. Okay, that's why here the AMU is important, the video EEG, the prolonged video EEG. But here we are talking about typical scenario. First here they are doing photic stimulation. Let's say they are doing induction by suggestion. They are telling the patient that now you may have seizure. You see that she turned her head to the right side and she started shaking. But the shaking is it's not synchronous. Okay? Now I will show you a true seizure to see the difference between the two of them. Plus, the patient is closing her eyes. Usually the true seizure, they don't close their eyes, they open the eyes widely, upward. Plus, if you see here the pelvis, what we call it pelvic thrusting. Okay? The true seizure, they are not doing the pelvic thrusting. This is what we call it pelvic thrusting. And you see, the left is shaking differently than the right, okay? Okay, and here you see the nurse elevated her hand up, and the patient didn't drop it over her face, she give it way, right? Okay, so the patient is conscious. Let's say she is conscious. Okay, and usually the psychogenic, when we wake them up, you see that they are clear-minded, they are conscious immediately. Usually the true seizure, after the end of the seizure, they are sleepy, they are confused, they don't answer immediately. Okay, they stay in bed for maybe 30 minutes, half an hour, sometimes 1 hour, not oriented, confused. Okay, in psychogenic, there are, after the spell, if I wake them up, no, okay, say your name, they say their name. That we give them during the seizure or the spell 2 words to remember. Why? Because if it is a true seizure, usually they don't remember. But most of the psychogenic, after 1 hour, if I ask them, yes, they can tell the 2 words. Some of them, they cannot tell. It doesn't mean that it is a true seizure. Sometimes maybe they are not concentrating, they are not listening, okay, they are living their spell, okay. But most of them, you see that they can tell. Okay, oh, you told me table and red color, for example, or elephant or red color.
Excuse me, sir. You said the psychogenic seizures, they don't burn themselves, but they will injure. Is there any specific reason for that? Or
Nobody knows why. Maybe they, I don't know. Nobody why. Nobody knows why. They're afraid maybe from burning themselves. I don't
but
know why.
injury they will make.
Yes,
So
dislocation.
this all psychogenic patients are doing by self. They will be conscious all the time.
Okay, now I will tell you what's happening. If you will ask yourself, how come this is psychogenic and they can do this and that for themselves? At the level of subconsciousness, they are knowing what they are doing, but they cannot control it. Those patients usually have severe depression, okay? They have severe anxiety disorders, they have mood disorders, they have post-traumatic stress disorder, loss of son, loss of money, death of parents, death of husband, death of whatever is the cause. Usually they are depressed, severely depressed or severely anxious. So they, let's say, they run away from their condition by doing these spells. Okay? Plus, they want this attention of the surroundings to them, as if they are telling we are suffering, I'm in bad condition, I'm in bad shape, I'm depressed, please, my parents, sisters, brothers, father, pay attention to me. If they don't pay attention to them, they do these spells as if they are seeking attention by the parents. That's why when we educate those patients, we don't tell that they are acting or faking. Okay? We don't say that this is fake. We say that this is a true spell, but they cannot control it. Okay? But the cause is psychological. Okay? Most of the patients they accept. Some they don't accept, but at the subconsciousness level, when I ask them, they know that they have something. If I ask them directly, do you have any problems when this started? Most they say yes, but some they deny. But later, when the rapport between me and them become more and more, they will tell yes, I have exams and I afraid to have bad marks. I have bad husband. I have bad wife. I have bad son. I have a son who is drug addicted. I lost my father last year. I lost $1 million, whatever is the cause. This is a psychiatric disease and should be treated adequately because this can ruin the life of the patient. Okay? And you see in your eyes that most of the cases, they come to us, okay, with on Capra, Dipakine, Tigritol. When they go to hospitals or doctors who doesn't have expertise in these conditions, they give them medication. And we know the side effects of the medication, the stigma of epilepsy in our society, oh, this patient is having epilepsy, so it can ruin the life of the patient. When I show them the video and the EEG, okay, and tell them the truth that God help us, or you have to thank your God because this is not true epilepsy, this is psychological condition, it can be treated, we have to do some psychotherapy, change the style of life to accept losses and so on. And I sometimes give them antidepressant and they become okay. Rarely we send them to psychiatrists because psychiatrists cannot deal with such patients. Okay? Now I will show you another seizure and you will see what I'm talking about. Okay? Now the aim of our topic today or our talk it's not the EEG, it's the clinical. Okay? Later we can have EEG changes. You see here, Diva came to the room, she saw something maybe on the computer here in this room, and the patient was asleep first. Okay? You see here that she is not responding. They are asking her, how are you, open your eyes, or raise your hand. She cannot. And you see here that she is having some oral automatism. Okay? And you see here she is holding her hands dystonically. When she examined her, she has some dystonia over the left. And you see, the eyes are open. And you see we have here dystonic posturing and then extension of both upper extremities and extension of lower extremities. And then the patient will have this vibratory phase. You see, this is vibratory phase. It's not a clonic, it's vibratory phase. Then after it, will have this clonic movement. That's why they call it generalized tonic first, tonic, vibratory, then clonic. That's why it is now it's in the clonic phase. So you see the difference between this spell and this spell. Okay, but by eyes, if you are in the first day in EMU or in epilepsy neurology, you cannot differentiate. For you, it's all seizures. Okay, but now some tricks you are now familiar with. Okay, you see, and after After the seizure stops, the patient kept confused, sleepy. She cannot sometimes talk for more than 1 hour sometimes. Okay? Now you see after 10 to 15 minutes she started to communicate with the nurses. Okay? And here the seizure, the spell, let's say, the EEG is normal like this. Here you see the patient was asleep, the EEG was normal. I will not focus on EEG findings, but by eyes, just by eyes, because not all of you familiar with EEG. You see here the dark red and dark blue, these are muscle. They are artifact, they are extending their legs, it's muscle artifact. Okay, but here you see these rhythmic spikes over the left. Okay, to make it clear here. This you cannot see it here. I cannot see it here. Okay, more or less here, but the most important is this part. This is the left temporal. So it's originating from the left temporal area and so on. You see, it's rhythmic spikes. Okay, to make things clear, this is, we don't see it here, right?
Yes.
Okay, so this wave doesn't exist here. So here, and it's rhythmic. So this is seizure. With the videos, it's a true seizure. And you see how she opened her eyes and screamed, ah! And she had this tonic phase, then vibratory phase, then clonic. This is a synchronous, rhythmic things. Totally different from the video that I showed you, right?
Yes.
Right? How we diagnose patient with epilepsy? Okay, so we are continuing with the case that I told you, 27-year-old man. The diagnosis relies, you see, most of our cases, we diagnose them by history, you see? The diagnosis is history, right? It's not EEG, not MRI. Epilepsy, we diagnose epilepsy. Most of the cases in my clinic, in my office, you see, I am confirmed that this is true seizure only by questioning the patient. Okay? How? It's by experience, it's by practice, right?
Yes.
But EEG, it comes to support my theory, to document, to confirm that this is a true seizure. But most of the epilepsy cases, we diagnose them by history. It's a clinical diagnosis, not by EEG nor by MRI. I do MRI to try to find a cause for their epilepsy. Okay, I do EEG to confirm that this is a true seizure and from where it's coming from, frontal, temporal, occipital, and so on. Okay, to put the syndrome. So EEG also can help me in deciding what is the best medication for this patient. Not all patients, if a patient is having absence epilepsy, like we see in childs, okay, they use awareness, when we are testing them during hyperventilation, they are not responding. Tigritol here and triliptal are contraindicated because the sodium channel blockers, they can increase the absence epilepsy. They can increase it. So it's not true and it's not right to give them sodium channel blockers for patients with childhood absence epilepsy or patients with idiopathic generalized epilepsy, like JME, juvenile myoclonic epilepsy, childhood absence epilepsy, or juvenile absence epilepsy. So the EEG is very important in deciding what type of medication I should give, right? So here you see EEG supports my diagnosis, right?
Yes.
Because most of the cases, if I do EEG, it's normal. And if by clinical history it's seizure, he is having seizure, it is epilepsy, but 3 hours EEG didn't show anything. So what? Doesn't mean that he doesn't have seizure or epilepsy. This is 3 hours couldn't capture these spikes. Okay? That's why sometimes we do more, 1 day, 2 days, 3 days to see what's going on. Okay? Seizure consists of spells. Okay? Seizure consists of spells. Loss of consciousness, loss of awareness, shaking. This is the most common, let's say. Okay? Loss of awareness. Loss of awareness doesn't mean loss of consciousness. Loss of consciousness, I can lose my consciousness now, but I can hear you. I can say, okay, okay, okay. And if you tell me raise your hand, I can raise, but I'm losing my consciousness. Awareness, there is no awareness. If you talk to me, my eyes are open, but I'm not here. Okay? This is loss of awareness. It doesn't mean that I should faint or fell to the floor. I can sit like this. I'm conscious, but I'm not aware. Okay? You talk to me, I'm just blinking my eyes. You ask me, raise your hand, I'm in a few seconds, okay, what you were talking about. Okay, so you see the difference between awareness and consciousness. So the true seizures, they are brief. Stereotypic, what we mean stereotypic, it's the same. Usually, if the patient is having, for example, temporal epilepsy, if they will see 4 or 5 seizures, usually they are the same. Okay? Or absence epilepsy, usually their seizures are the same. They blink their eyes, they lose awareness, they are not responding, okay? And they are stereotypic, the same. Okay? Psychogenic, they are not the same. They can develop different type of spells. Sometimes they lose consciousness, sometimes they fall down, sometimes they shake their legs, and so on. In the true seizures, we have a clear beginning, like we saw here in our case, and a clear ending. Okay? She lost consciousness, opened their eyes, started shaking, okay, and at the end, when the seizure stopped, it stopped immediately. Okay, so we have clear of evolution. Evolution, it slightly increases, then it decreases, and it stops. So I have a clear beginning, and evolution, and a clear ending. Okay, and usually they are associated with EEG changes, like in our case. Clear? So, if we have patients, when we ask you, or Ahmed Midhat, or Dr. Midhat, or Dr. Amir ask you the patient, do we have seizure? You say, yes, he had seizure if I have a true seizure with a true EEG file. If the patient have only jerks, you say, he had a spell. Okay, I will ask you, what type of spell? You say, he had myoclonic jerk. He had dyspnea. He had headache. But if you say for me, yes, doctor, he had 5 yesterday, I tell you what, he had headache and he pressed the push button event. This is not seizure. Okay? You say that he had spell. If the seizure is like this, yes, it is a seizure. You say that, doctor, he had seizure. I will ask you what type of seizure. You will say complex partial seizure, and I will tell you what means by complex, or simple partial seizure, or GTC. Like in this case, you will say, the patient yesterday had GTC. It's clear. Okay? So when I start reading the EEG, I'm in my subconsciousness that this patient is having seizure. But not any spell is seizure. Okay? So here we continue in this case that you remember, 27 who presented to the ER with loss of consciousness. In the emergency unit, he was noted to be drowsy and confused. Half an hour later, he is back to normal and he was amnestic to the event. He doesn't remember what happened. Amnesia. Witness reported generalized tonic-clonic movement with urinary incontinence. Till now, okay, if I ask the witness, oh, he will tell me that he shaked. But the witness is not doctor.
Yes.
He may have seen that any shaking is seizure. And doctor, he had urinary incontinence. Okay, you can say, oh, this is a seizure. But not always like this. Okay? But from these findings, at least we are, let's say, 50-50 sure that this is a true seizure. Okay? Because he is drowsy, confused, half an hour later, back to normal, and he doesn't remember what happened. Okay? The witness surrounded, we asked the parent, the witness, what happened, he will tell us that he shaked and he had urinary incontinence. Okay. But remember, urinary incontinence can be present with patient with syncope or psychogenic, right? So now our patient had a spell. Okay? We are now convinced that this is a seizure, not a syncope, because in the emergency unit we excluded everything. If here in world, you take blood pressure, vital signs, blood sugar, sodium, potassium, whatever, or imaging CT, everything is normal. So this is not psychogenic, this is not syncope, this is not parasomnia. So this is a seizure, right? Seizure, not epilepsy, seizure. Okay? So next question I have to ask myself, is the seizure provoked or non-provoked? Why this is important? Because provoked seizure can be provoked by sleep deprivation. The patient didn't sleep yesterday, and he had a party, New Year evening, okay, drinking, okay, and he had a seizure at 5 a.m. This is provoked by sleep deprivation. Unprovoked is I'm not doing anything, sitting like this and I fell down. This is unprovoked. There is no cause, okay? Yani no hyponatremia, no hypoglycemia, no hypocalcemia. This is seizure without cause, okay? So my question to myself is to define, is his seizure provoked or unprovoked? So this is the algorithm how, but this in seconds we think about it, okay? So here, in the emergency, in the ward, okay, they did all the panel, okay, sodium, glucose, sodium, calcium, saturation, alcohol withdrawal, because sometimes alcohol withdrawal if the patient is drinking a lot and he stopped immediately, they can have seizure. Tramal withdrawal can have seizure. Red Bull in children, sometimes one kid came to my clinic, he drank maybe 6 bottles or 7 bottles of Red Bull with his guys or his friend, he had seizure. Sometimes it can provoke seizure. Medication, okay, like as I said, some antibiotics, some medication withdrawal like Tramal, antibiotics, they can cause seizure. Acute insult to brain, stroke, IC bleed, AVM, aneurysm. Nothing from these, so it is unprovoked. Something from this, it is provoked. Why this is important? Because if the seizure is provoked, you need to treat. I should not give medication until because if he has hypoglycemia, the blood sugar is 2. If I correct the blood sugar, he will not have seizure. You see why this is important? Okay. If he has hyponatremia, 125, 120 sodium, I correct the sodium, he will not have seizure. So no need to give anti-epileptic. That's why this question is important to me, to ask, to answer it. Okay? So it is not it's not provoked, it is unprovoked. So he had one seizure that was unprovoked. Okay? He had single seizure, right? If he has single seizure, he doesn't have epilepsy. If he will tell you that, oh, 1 month ago I had the same, so he has epilepsy. If this is the first time, he has only one seizure. If he say he has, you see, we continue. On direct questioning the patient, he reported previous similar episodes. So, it is epilepsy. Okay? What kind of epilepsy? It's different topic. Because we should have EEG and history to put an electroclinical syndrome. Okay? So, this is unprovoked seizure. Single, not single. It's 2. Next question immediately I will ask myself, is this partial or generalized? Partial originates from one area in the brain and it generalized to all over the brain. Like in our case, it started from the left temporal and it generalized. So this is partial epilepsy. Okay? If it's generalized, like in patient with childhood absence epilepsy, juvenile myoclonic epilepsy, we don't have focality. The patient immediately have generalized tonic-clonic seizure, and on the EEG, I don't have focal spikes from one area in the brain. I have a generalized spike wave discharges. Okay? Absence or any generalized epileptic discharges. You see? So, we come to the last question. This is partial or this is very important. Why, as Mahmoud said, because the treatment here is different than the treatment. The prognosis here is different than the prognosis. I I should know what type of epilepsy the patient has. Because the plan is different, treatment is different, prognosis is different. Patients with benign Rolandic epilepsy, they have good prognosis. I can tell the parent that when they reach puberty, we can stop the medication, for example. If they have childhood absence epilepsy, because it's an age-related disease, I can tell them, although it's generalized epilepsy and they are taking Dipakine or Zaruntine, I can tell them, if they ask me, that at the age of 15, 14, if the AG will normalize, I can stop the medication. But in patients with juvenile myoclonic epilepsy, I tell them this is a lifelong treatment. If the patient has focal epilepsy, I tell them it's a lifelong treatment if he is not a surgery candidate. If we do surgery for this patient, if he has, for example, angioma over the left temporal, and I remove it, he can be seizure-free. You see the difference in the prognosis and the treatment in planning? That's why you see us searching what type of epilepsy, what is the diagnosis, what is the syndrome, okay? We are reviewing the medication, so this is the wrong medication, let's change it. It's not because we like to do this, okay? Because this depends on the long-term treatment and the plan. So the seizure classification, okay, if it's partial, it originates from one area of the brain, and it's spread, when it's spread to involve the all part of the brain, okay, it's spread to involve the other side of the brain, it will become complex partial seizure. Simple partial seizure, it means that the patient is having focal seizure. For example, I'm shaking in my left hand, but when you are talking to me, I answer you. Oh, doctor, my hand is shaking. Okay, what's your name? My name is Ahmed. This is simple partial seizure because I didn't lose awareness, because the seizure was here and it kept occurring here. If it's spread to involve the other side of the brain, I have the focal seizure, you talk to me, I'm not answering. Okay, I turn the head. This is a complex partial seizure. It occurs with loss of awareness. Okay? If it's spread to involve all the brain, the patient will shake all over and she will develop or he will develop a generalized tonic-clonic seizure. So here you see that the seizure started again. You see? Here, Deepa entered the room. So she is not answering the questions given by Deepa. Okay, raise your hand and Rani. This is complex till here. This was complex partial seizure. Okay? When it spread to involve all these areas of the brain, okay, she developed the generalized tonic-clonic seizure. Here, she's having seizure. This is seizure. But this is partial seizure. We call it complex partial because the patient lost awareness. If they can't speak and respond, this is simple partial. Okay? Is it clear?
Yes.
Okay, so simple partial seizure awareness is normal. It can be motor. The patient will tell you, I feel numbness, sensory, autonomic, and my heart is beating, my heart psychic, some confusion. Okay, complex partial seizure awareness affected. Okay, secondarily generalized tonic-clonic seizure, loss of consciousness. So simple partial seizure can have only simple partial seizure, but sometimes it can spread to be complex partial seizure, and sometimes it can spread to involuntary seizure. Sometimes I only have simple partial seizure. The patient, this is lose consciousness and have focal seizure, you say he had simple partial seizure. He had loss of awareness. Let's assume that this patient had the seizure here and stopped, and we see it a lot, right? Okay? Till here, okay? She is not responding and it stopped. Okay, and she slept and become confused. You say that the patient developed complex partial seizure. Okay? If it's spread to have GCC, you say that she had complex partial seizure with secondary generalized tonic-clonic seizure. But sometimes I see only simple partial, I can see complex, and sometimes I see immediately generalized tonic without any signs. He was sleeping, immediately he had GDC. Okay? I will stop here. Okay? Next, I will talk about the several types, because we have word now. Okay? Several types of generalized idiopathic general epilepsy. So you will know what do we mean when we say it's idiopathic general epilepsy, childhood absence epilepsy, juvenile? What are the difference between them? Okay, and we'll focus about some focal epilepsy. Okay, now till now, is it clear how we have or we should approach patient with coming with a spell? Okay, and how we reach that he's having seizure, and how we reach our diagnosis? Okay, based on videos, based on EEG. Okay? For example, concerning focal epilepsy, to see what we mean by focal epilepsy, I will show you now video. It's a simple partial seizure. So I told you, it's focal seizure, but the patient is awake, conscious, he's answering the questions given by the nurses. It's in French. They are asking him, comment tu t'appelles, what's your name? You see?
Donne-moi
He
ta
started
main.
having
Donne-moi ta main, Antoine.
mouth deviation and
Qu'est-ce que c'est que
twitches
ça,
in the
Antoine?
face.
Qu'est-ce que c'est que ça, Antoine?
See, this is focal seizure, but simple partial seizure.
Regarde-moi, donne-moi ta main.
Huh? He can raise his hand, give me your hand. He's awake.
Ça va,
This is
Antoine?
a simple partial seizure. But
Oui.
this is seizure,
Qu'est-ce que c'est que
okay?
ça, Antoine?
What is this? This is pen. He's saying in French.
Regarde-moi, donne-moi ta main.
Give me your right hand. He gave her right hand, but this was seizure, right?
Oui.
Complete partial seizure, what I showed you.
معلش يا دكتور، يبقى في برضه نفس كده بس ما بيقدرش يتكلم، يبقى برضه عنده فيكال توتشنج بس مش قادر.
Complex partial seizure.
كومبلكس ولا سيمبل؟
Complex.
كومبلكس. هو بيقول انا سامعك هو بس مش قادر ارد.
بتكون simple. Oral automatism, she can't answer, this is complex partial seizure. Right? Because not all simple partial or complex partial seizure I should have motor. I showed you the slide. Motor, sensory, psychic, autonomic. He can have focal seizure but doesn't moving. He's only having heart beating, palpitation, or sensory, or he cannot respond. We are doing here photic stimulation for the patient. You see how she will have these jerks. These are not focal epilepsy, this is generalized epilepsy. Okay, in the next lecture I will show you what is the difference. So this is my tonic jerks, okay, that was induced by photic stimulation. Tonic seizure. Increase in the tone, you see, this is a different type of seizure, tonic, like this. Okay, this is tonic seizure, and he is not responding, he is having absence, loss of awareness. You see, he is not responding. Okay. Here we are doing hyperventilation. Okay. Now we see what we mean by loss of awareness and not responding during hyperventilation in patient who is having idiopathic generalized epilepsy or absence. Okay. You see, she have myoclonic jerks, and she started blinking eyes, not responding, then back to normal. On the EEG, we saw generalized spike wave disorder. This is not focal epilepsy, this is generalized epilepsy. The difference in the next lecture, but now, till now, the approach to you is clear, how we reach the diagnosis of epilepsy, provoked, unprovoked. We eliminate all the differential diagnoses, and now we have to ask ourselves partial or generalized. Partial, you know that what is simple partial, complex partial, GTC. In the next lecture, we will talk about idiopathic generalized epilepsy with the